all ninjas. It's time for Lyme Ninja Radio.
Healing from Lyme disease isn't about doing a million different things. It's about finding the few things that work and then sticking with it. Since 2015, McKay Rippey has been encouraging folks to never give up. Lyme disease causes all kinds of problems, and focusing only on killing bugs leads to diminishing returns. That's why generic cookie cutter treatments don't work. You need to fight Lyme like a ninja. If that sounds like a plan, keep listening. And if you want to know more, visit us at lymeninjaradio.com. Here's your host, McKay Rippey.
Hello, hello, hello. It's Tuesday evening, and it must be time for the Lyme Ninja Radio Show. Woohoo!
Woohoo! Let's just take a moment of commiseration for upstate New York because it is snowing on May 12th.
I just looked out the window. It's still actually snowing. It's no joke. Yeah. Yes.
Yep.
It's even accumulating a little bit. So.
Yep. So a moment of silence for upstate New York and our spring, quote unquote.
April is the cruelest month, said the poet, but apparently May is also. Anyway, we're happy you're here. It makes our snowy May 12th so much better to spend some time with you. Our guest today is Sommer DelSignore. She works with Dr. Bach downstate, kind of like to the east and then down south. And we were going to have a discussion about co-infections and pediatric Lyme. However, she has not logged on yet, and we're not exactly sure what's going on. She is actually practicing medicine, telemedicine, so she could be hung up or late with the patients. We'll do our best. We'll just hang out here for a while to see if she comes. If not, it's just you and us, which isn't such a bad thing.
Dun, dun.
So let us know where you're from. We'd love to hear. Say hello to you. Christine, always good to see you. We're so happy you're here.
Oh, you have snow too.
Excellent. Misery loves company, as they say.
Oh, yes.
So go ahead and let us know where you're from so we can say hi. And as you know, Lyme disease is an international problem as well as a national problem. It's not just stuck in the Northeast here. It's all over the U.S., maybe a little bit less in the middle of the desert somewhere, but they have other fun tick-borne diseases there. So let us know where you're from. And in the meantime, Aurora, why don't you give us the top 10 cities for the past week?
Okay. Drum roll, please. Starting in at number 10. There you go. Is Salina, Oklahoma. Number 9 is Charlottesville, Virginia. Number 8, Oak Park, Illinois. Number 7, Hopkins, Minnesota. Number 6, Steinbach, Canada. Number 5, Two Harbors, Minnesota. Number 4, Buin, Chile. Number 3, Ashburn, Virginia. Number 2, Paris, France. And number 1, Santiago, Chile.
Hey, that's awesome.
I'm very excited that this week we have 2 cities from Chile. We're spreading in that country, apparently.
We're contagious.
Yes. Santiago was apparently the vector there.
Wow.
We're
all experts in public medicine. And Sommer has just joined us. So Sommer, we're going to bring you on screen in just a moment. So hang on. Excellent. Aurora, perfect timing, actually. So why don't you give us a little bit more information about Sommer?
Sure. So Sommer is a veteran board-certified pediatric nurse practitioner and a member of ILADS. Sommer trained in some of the top pediatric hospitals in the country, including the Children's Hospital of Philadelphia, the Children's of Dallas, Texas, Penn State Childrens in Hershey, Pennsylvania, and most recently, Levine Children's Hospital in Charlotte, North Carolina. She completed a Lyme disease internship with Richard Horowitz. She currently works with Ken Bach, an expert in autism and PANS PANDAS, And Sommer specializes in the treatment of autoimmune neuroinflammatory conditions, Lyme and other tick-borne illnesses, and mycotoxicosis or mold exposures. She works with Dr. Bach as a pediatric Lyme specialist, medical writer/blogger, and a consultant to other healthcare providers.
That was excellently read. Thanks, Aurora. We'll bring you back up in a little bit. In the meantime, say goodbye. And Sommer, say hello.
Hello. Thank you for having me.
I'm so excited you're here. You really have no idea how excited I am that you're here.
Oh, me too. I'm excited that I could log on.
Yes, exactly.
Technical.
Whenever we cut things this close, it's always a bit of a hold the breath and hope things go. Let's just say hello to Kathy here. Hello, Kathy. Aurora gave us your background, kind of, the back of the book. When you write your book, that'll be on the back of your book.
Eventually, right?
Yes, but what I want to know is why pediatrics?
Interesting. It's always been pediatrics for me. It has been, and I blame it on a rather aggressive instructor way back in the day. Who on the adult, one of the adult units, we were, going through our clinical rounds, and she kind of made me do something I didn't want to, and didn't prepare me for it. So I said, nope, that's it. Pediatrics it is. So it was more of a defiant move at that moment. And then moving on, when I did actually train in pediatrics, I thought, this is for me.
Yeah.
So,
it's just important to know what you don't want to do. As much
absolutely.
As, right. Yeah.
Right.
And then the segue to Dr. Bach at Lyme disease.
That was an interesting path. And the intro, with the bio always sounds a little pompous when I hear it, and I cringe, but there's a reason, just to say, I started off in a very non-integrative, non-primary world. It was always very mainstream, follow protocols, pediatric ICU, sick of the sickest. And for a while there, I didn't know what a healthy child was supposed to look like and act like. And just kind of as I evolved, as we all do, you start to question what you're doing, why you're doing it. And, as I sort of researched, some of the ongoing issues that we saw in the ICU, I would kind of throw things out there to say, hey, why don't we try this? And it may have been something integrative, like, let's give them a probiotic. And I get the stares like I had 3 heads, oh my gosh, no. And I'm thinking, but why? Why not? So, that just kind of led me down that pathway, just asking those why questions. And eventually I transitioned from those hardcore ICUs, adrenaline driven kind of places, to more of that primary care. Let me see what a healthy child looks like. I may want to have them one day, it'd be good to know. And that just continued that path. So it's kind of funny where I started off and where I've ended up, never thinking that I would be more, out in the primary world, and certainly not in integrative care whatsoever. But it was, seeing, just having an open mind and saying there has to be a better way. And those were the questions I asked myself constantly. And primary care led to an integrative practice, which then led to joining up with Dr. Bach about 4 years ago. And it was just that ever evolving. In the primary practice, we started to see a large percentage of kids with Lyme at the time. And again, I didn't really know. I would just kind of follow protocols to say, well, let me treat the way you're supposed to, right? Based on CDC, just like any pretty fairly novice provider would do. And then I would kind of see this sort of sequela to that, and these sort of side effects that were sort of lasting, and they weren't necessarily severe. It's almost like that kind of frog in the warm water, and you heat it up, and so it wasn't that evident at the time. But then I would start making other connections and seeing sort of these chronic illnesses with these kids, just, more behavioral related, and more infections would occur after the Lyme. I'm like, wow, they've had a really big uptick, and I can't explain it. And then that led me to more of integrative medicine to say, all right, let's look at this differently, because antibiotics aren't going to do it alone, so I want to make that clear. Yes, we do use them, but then, those, further investigating led me to integrative med, and then specializing in what I do now with children. And it was interesting when I eventually connected with Dr. Horowitz. One of the first things he said to me, he's like, you really need to come and train with me, because you are essentially one of the only pediatric Lyme, providers in this area. You've got to do this. And the gravity of that, so that was sort of my calling at that moment, and it has been ever since. So, yeah, my journey's not over. We'll see what happens next.
Well, it never is. So funny story is, when I started my acupuncture training 100 years ago, we did classes not by when you graduated, but when you started studying. And their specific reason for doing that was, you're just starting now and you will never stop. So don't, you basically, we're going to graduate you so you don't go out there and hurt anybody.
Right.
And so you better figure out the rest as you go along. And so, and anybody worth their salt is still learning. I mean, it's sad when you see a physician burn out, where they just can no longer take in new information. They're just holding on with their fingernails for dear life.
Right.
And, some of them take 6 months off or a year off. It's a brutal world out there. So we're happy. We are happy to have you. There is, and I always blank on her name, up in Albany area. Who's the other Lyme pediatric physician? Okay. I'll get her your name, because you guys at least should know each other, because there are, you guys are rarer than hen's teeth. Really, it's hard enough to find
for that one.
Yeah, really, it's hard enough to find an LLMD, but a pediatric LLMD practitioner is really tough. And so I do want to ask you first, before we get into the pediatric side of things, about co-infections. And I realize they can vary even from season to season, but definitely regionally. What are you seeing? And you're downstate compared to me. I know you call it upstate from New York City, but for me, you're downstate. Right. So you're in the Hudson Valley, about halfway up in between New York City and Albany. So what do you see down there in terms of co-infections?
In addition to Lyme, I see a great deal of Bartonella, and probably closely followed with Babesia. So if I were to put them in order, Lyme, Bartonella, Babesia, and then Rickettsia. So, but huge cases of Bartonella, primarily clinical in nature. And what happens is, you start to treat it. It's such a slow growing small bug. It's hard to capture, but you see the striae, you see the neurological changes and the nightmares and the neuropathy that can't be explained. And, they come to practitioners like you, or they go see their chiropractors, and they're cutting out dairy and gluten, and they're, seeing every rheumatologist under the sun, and pain. Yeah. So, so we, so I see a great deal of that. And then I find that after we start treating, and kind of temper the load a bit, and kind of help the immune system see what it needs to see, that titer will pop up much later, even after the patient starts to feel better. And so it's a great deal. There's a hand.
I saw it. Hi, hand.
No, I got one.
Hello.
That's my youngest. But
what's his name?
That's Noah.
Hi, Noah.
That's my 9-year-old. Yes, he keeps me on my toes. But it takes a great deal of effort to convince the patients to say, just trust me. This is here, I promise. So, Yeah.
And then how long do you find it takes for the, like you said, for the test to show positive? Do you keep on testing just to kind of prove your point? Or do you just, if they say, trust me, is that enough? And we're just going to treat it and see the clinical improvements?
Depends on the person. So routinely, I will test about every 6 weeks. So I try to take the patients through initially. I like to take the patients through a treatment cycle, knowing most critters, about 30 days or so, right?
Mm-hmm.
So I'm looking for proliferation. And many times even treating every 6 weeks, I'm not necessarily going to change the treatment at the moment, but I'm just seeing what shifts occur. And when I test, it's never a myopic approach. It is Lyme and all co-infections, because there's sort of this shape-shift way of these little bugs and the immune system. I joke around with a lot of patients and say, not to offend you, but it's like a dude. It's not really great at multitasking and it can only focus on maybe one or two things at a time. If we get a handle on that, you may see other things kind of bubble up that have always been there. So not to offend, we women think we can multitask and we really can't, but we still haven't figured that out yet. But
that's another conversation for another
conversation. Yes.
So to totally interrupt you here. So when my female patients come in at a certain age and things begin to change again, I at some point, usually after they've kind of gotten over the shock, I say, and now you know what your husband goes through. Because estrogen's like the super mental drug. And you guys can like remember everything and think of a million things at a time.
Right.
And we are. And just one thing at a time in front of me. And don't talk to me while I'm looking at something else, because it's in one ear and out the other. So I'm not offended. We're talking about biological reality here. And
absolutely.
It's just the way it is. So, no, it's all good.
We have to make light of it. This is some serious stuff,
Yeah. My wife did that she did it today. I was watching a YouTube video. I got sucked in, and she says, I'm making turkey soup for you. You come here and I want you to look at the turkey soup. So, this is your turkey soup. And I'm saying, okay, I got it. And I'm trying not to be offended when she was doing that. But if she hadn't done that, I probably would, it's like, where's that turkey soup that you told me about?
Right.
If I even remember it. Anyway, we were talking about co-infections and particularly Bartonella.
Right.
And so my youngest daughter, I'm pretty sure has Bartonella and has had some bizarre things throughout her life just kind of show up. And she does have the stretch marks, right? For a young woman. It's like, especially when she started showing up and she was all of 17, 18. It's like, what are you doing with stretch marks?
Right.
Like, you're a little young for that. And that's kind of before I knew a whole lot about Bartonella. But one of the strangest things she had happen was she had, and this is 4 years ago, kind of this undiagnosed, undefined meningitis episode that lasted. She had basically two or three ER events over a week's time. And the last one, we kind of brought her back home and she was at home when it happened. And it was one of the worst nights of my life. I mean, she was just absolutely in incredible amounts of pain. The ER doctor, at least he started out thinking, well, it's probably just a migraine, but they did this tap and it came back a little. He said, I don't know what this is. There's something abnormal here, so I'm just going to give it some undefined meningitis diagnosis. And, he was very sympathetic, but didn't have a lot to give us at that point. So it's crazy. So her symptoms were acute headaches, right? And just, and to see somebody in that much pain, they basically lose their mind as well. But it's funny how these diseases affect children differently. Right. And so, and you began to mention the psychiatric side of things. And so what do you see? What are some of the signs that a child has an infection like this? And I'm even going to toss mold in there. Let's just toss mold in for fun because,
absolutely.
they fire up the same pathways, right?
Absolutely. Well, typically when a child presents, we're always looking at milestones and trying to determine, through history, is this something organic that's just sort of starting to emerge as they're growing, especially if they're hitting puberty, and you kind of really have to trace it back to say, have you noticed these soft signs? If you really look back, hindsight's 2020, because again, we're not dealing with an adult who had symptoms, we're dealing with a kid who's still developing. So you kind of have to keep that in mind. But what I find is that typically these children have absolutely no neurological history whatsoever. And then all of a sudden, almost like flipping a switch, you end up with kids who are highly anxious or develop severe OCD patterns. And it can be something that isn't quite impacting their daily life yet, from, they're a little germophobic, to washing their hands 15 times a day, to having to, tap the threshold before they could walk through it, kind of things that can be quite impeding their abilities to just live life. Severe outbursts, major concentration issues, even, some pretty significant depression can be involved with it, and overall personality changes. A lot of the, initial symptoms that I'll notice is that a parent will say, well, I really started noticing that they weren't sleeping well. They were waking up with kind of like a night terror, as if they were, a toddler again. And then it progressed to they just couldn't focus in school, and they would just have outbursts. But we just thought it was related to their ability, that maybe something was hard, difficult for them to comprehend, or a difficult subject in school, and they just couldn't grasp it. And then, you start digging more and more, and you say, well, there's some pretty significant neurological changes. So in addition to things like the headache and fatigue, which could be 1,000 things, really, and the general pain and muscle twitch that you can sometimes see, which again could be many, many things. It's all that inflammatory component. So where you see children are different from adults is the blood-brain barrier. It isn't quite healed, sealed as tightly as it is in adults. So children are, and meaning in my description of children are, 0 to 22, essentially, is that kids are quicker to develop more of an autoantibody response if the cards line up right. Underlying genetic SNPs, other environmental exposures, yada yada. Health of the gut, all those things add in. But that blood-brain barrier is more vulnerable. So then you get that inflammatory response. Those, autoantibodies cross over, and you get inflammation. There are a couple of colleagues who actually focus their efforts on this. Dr. Fallon is big into the whole neurological component and looking at Lyme, Lyme. There were some studies, and I'll have to find them, where they were performing SPECT scans on these kids and seeing that sort of cortical, subcortical areas of the brain were lighting up. They were inflamed. So, the problem with the neurological component is that, which we refer to as more of like an autoimmune encephalopathy, kind of comes and goes, versus like, an acute meningitis, I'm in the hospital on IV antibiotic kind of thing, but it comes and goes, like with your daughter, the headaches, sometimes with the mood, changes, and the concentration issues and the sleep issues, and it kind of comes and goes. And it's very difficult to, unless you're in kind of this area of practice, I think it's difficult for providers, especially if they're taking their kids to urgent care, to really connect the dots and say, oh, well, maybe they're just making this up, or maybe they're just looking for attention, or maybe it's just a viral thing, it'll pass. That's what I hear often. And these are well-intentioned providers. They just, I just don't think that they know. So, yeah.
So let's pause there, because you hit on maybe the most important issue that we're struggling with right now. So when I got started doing this podcast, whatever it was, 5.5 years ago, the main issue was just awareness in general, right? And now the awareness is out there. It's not, Lyme disease is this, exotic thing that just is in the Hudson Valley. It's really, people have the sense that it's all over the place. And for the most part, I hear story after story of diagnoses happening, I like to say, over the backyard fence. So somebody will mention in passing, we just had a young man on here who wrote a book, and his diagnosis started from, he was getting some scan for something, and the nurse said offhandedly, or the tech transporting him said, "Oh, that sounds like Lyme disease." And that was it. Right. Mm-hmm. And so that started his journey into looking into it. And sure enough, a couple of years later after that, or 6 months or whatever it was. So how do we get physicians aware of this? Because you have one message coming down from on top here. I got to go in the screen here. One message coming from right, and then we've got reality underneath, right? And again, physicians are maxed out. They're not trying to do a bad job. They're trying to filter in good information from bad information. And just, just what's happened with COVID. Now everybody is at home broadcasting something on Zoom, right? The amount of information is literally overwhelming. And some of these people are credentialed too. It's not, like I'm just a guy with who sticks needles in people and has been talking to people with Lyme disease. But there's some fairly well-credentialed people out there creating content. So who do you listen to? How do you get that information out?
Yeah.
Any answers?
I don't think there's an easy answer to it. I mean, I think that I find today that, medicine is so incredibly siloed, and that there are governing bodies per specialty, and they're just not talking. And because they're not talking, they're not connecting those symptoms. I think that it really has to come from the top. We have those two big organizations on both sides of the fence with Lyme, and until they can come to some sort of a collaborative agreement, I don't know.
Okay, so let's kidnap them, take them to a cabin somewhere in the Adirondacks, lock them inside. Right. It's kind of like how they choose a pope, right? And just keep them in there, and then when the white smoke comes out, we'll all be good.
There you go. Exactly. It's a tough one. It's a tough one.
Well, I know Horowitz has this dream, and he's been working on starting a curriculum in a medical school. And I thought that was ambitious and wonderful. I haven't heard any update recently, but that's, something like that, is a start. But that's still, even if he does that, there's still, you're not the expert, right? You're not the Dr. Fauci of the Lyme disease world. Right. And that, unfortunately or fortunately, depending on where you sit, that carries a ton of weight. Actually, my daughter, who was on the screen earlier, she's doing a nutrition course out of Cornell. And so one of the things they teach, and this actually drives me nuts because I'm out on the fringe, but they teach them that one of the things you have to look at looking at research is the author and the institution is coming out of credible. Right. So that's one of the things. So who determines credible? I read all kinds of funny stories. I was just reading a paper on peroxynitrite. I struggled all weekend reading this chemical. Right. Anyway, brutal. And it was out of a small university in Paraguay. And it's this wonderful summation of all the recent research up to like 3 years ago. And it was a great introduction to me. Now, I'm not going to throw that away because, everything's documented. I checked out a bunch of the studies that they had too. It's not like they were making stuff up, but they're not, that's not somebody's going to turn to, let's go check out and see what the University of Paraguay is doing, on the peroxynitrite research. It's like, no, we're going to move that aside and I'm going to listen to, anyway. I'm on a soapbox. Get me off my soapbox. Stop it.
Oh, that's okay.
Good grief. All right. So
I hear you though.
Yeah, it's I mean, that's what science is about. Not about who's got the fanciest cap and gown, but or the best bumper stickers, like who produces the results. And and the history, I'm back on my soapbox. I can't help it. The history over and over and over again points to the people on the fringe making the breakthroughs. I mean, go back to tuberculosis, hand washing, for goodness sake.
Right.
All the experts say, what are you doing washing your hands? You're an idiot, right? The guy ends up, Semmelweis ends up in an insane asylum, right? He lost his life. He lost his mind. He lost his fortune because he wanted people to wash their hands. And now that's all we hear 24 hours a day is wash your hands, wash your hands. But the experts told him he was nuts. And that's not that long ago.
Yeah.
That's not like that's 500 years ago. That's only like what, 150, 200 years ago.
Well, I mean, I always live by the saying that, people will always reject the unfamiliar. And eventually it will eventually evolve. Hopefully. I have to be optimistic and assume that there has to be, a breaking point where we surmount this great deal of data to the point that it's, undeniable. But, that's my positive spin, hopefully.
Yes. So that brings up another very interesting question. I'll try to ask it and be quiet. So how because I know down there you guys are doing all kinds of very, very interesting interventions and treatments. How do you decide whether to bring something in? Because there's not what you're doing. There's not a whole lot. There's maybe some clinical validation here, but
right. Well, it's, the first question that we always ask is, will this do harm? If we try this, are we really going to create more harm than good with those patients? And we do our due diligence and look at clinical studies and look at the science behind it. And I'm very slow to bring on some of the treatments that we do with the children until we've kind of used it on the adults first. So I look at my colleague, Dr. Bach, and I'm like, you go ahead. See how that works.
Let me know how that goes.
And then, but then there are things that are still questioned, but there's a ton of data. So things like ozone. That's something I use quite frequently with a lot of my kids. And there's a great deal of data, but then, you're always evaluating risks and benefits of everything you do. So, it's some things you just kind of have to go for it in a smart way and try to determine all the potential risks and benefits and side effects and have that open discussion with your patients, full transparency. And many of them are willing to go and give it a try, and some are not, and we don't push the issue any further. But it's tricky sometimes, kind of being on the fringe of you, as you've said, because we're kind of pioneering a lot of these treatments, and they're not necessarily foreign. It's just they haven't been used in this way for this type of, a disease process or an illness process per se. So,
can you help me with ozone treatment? Because I get stuck, and I had this explained to me recently, and my brain could hold the information for about 30 seconds, and then it snapped back to its original. So ozone is a very, very reactive chemical, right? It reacts with everything. How come it doesn't do more damage in a human being?
Well, in a human being, it's very different. So it isn't ozone as in, the ozone layer, there's a big hole, yada, yada. So in the body, it's almost more like, a modulator. So it is really functioning more on NAD and NADH in the body. Okay. So yes, it's O3. Yes, it's the reactive series. Yes, it can technically cause inflammation, but it can also calm it down. So it's there to balance, which is fascinating. And I've certified in it. I've gone to all of the classes and I've had it explained, and I'll say, yes, I understand it, but I still always question, how the heck does it do it? But really it's working on NAD and NADH in the body. And that makes sense to me. Well, if it's imbalanced, it's going to help to kind of potentiate what it needs to, calm down the other. So
any particular, so everybody forgive us for a second, but I have to get a little bit geeky here. Any particular part, is it part of the creation pathway of it, or just the balance between NAD, NADPH, and all the four little variations of that.
It seems to be, my understanding is part of the balance of it. Yeah, primarily. My understanding too is that it can also sort of ignite that process as well. So people do have a slight inflammatory response initially as we're revving up that treatment.
Yep.
But it primarily is there to kind of temper some of those responses as well.
Okay, so let's open this up to the people who are watching us. And there are some questions already, and let me just sort through them here and see what we find. And we'll just go a few more minutes here.
Sure.
So actually, a lot of these are kind of comments about some of the big picture stuff that we talked about. But let's start here. Julie talks about Bartonella being confused with autism.
Oh, absolutely. Absolutely. There are some very controversial studies bubbling and brewing that are linking kids who have been diagnosed with autism as actually having underlying infections, Bartonella and other co-infections. And I could totally agree with that, from what I've seen clinically as well. Some of those similar symptoms that we see with Bartonella from the kind of the OCD, the mood component, the dysregulation, very similar to a child who has been diagnosed with autism. So good connection there with that.
And then also comes to mind, of course, just kind of the rampant, especially with the high achieving crowd and the college crowd, is just the anxiety and the level of antidepressant and anxiety drugs that are prescribed. I mean, we're up here near a college, and the numbers are astonishing about the percentage of those young people who are on meds, who are on psych meds.
Yeah. There was a study by Dr. Greenberg. She's an adolescent psychiatrist. And she did it was a small study. It was about 14 or 15 kids. And essentially, they were all diagnosed with forms of with bipolar or other kind of mood or psychiatric disorders, and were not as responsive to medications. And out of the 14, all of them had some sort of a co-infection underlying, and only one of them actually had like physical symptoms of like a joint pain and fatigue, but it was all neurological. It was all behavioral. So, I really feel that, and then Bransfield was the one who was looking into sort of the studies with the autism and linked with Lyme co-infection. But, I find that many children, or I feel that many children are misdiagnosed with mental health issues. And clearly it's some sort of an underlying infection of sorts, whether it be tick or tick-borne co-infections. And then, the side effects, neurological side effects of those versus it being a true, neurotransmitter issue. It's typically an inflammatory issue related to the bugs.
Underlying it all, right?
Right.
So this is interesting because this actually popped in my mind too. So many adults, right? Many patients needs to start off with tiny, tiny doses, and children are even smaller, and they're not just little adults, they're children. They're, like you mentioned with the blood-brain barrier, their chemistry, their biology is different. Right. So how small do you start with children on dosage?
Well, dosage is based on milligram per kilogram.
Okay.
So it's always been, so it's never one size fits all. And, based upon the history, that I get from the parent, sort of like, well, how does your kid react to, if you give them Motrin or Tylenol, do they get super sleepy with it? So I ask about certain things with dietary and medications and supplements that they've given their children in the past, just to get a good sense of, their level of sensitivity. So there's the standard milligram per kilogram dose. And if their child seems super sensitive to certain things or has a ton of allergies and seems like they have, inflammatory process like a mast cell or something else going on, we'll start, a quarter of that dose. And then I'll work my way up. So it can take weeks, sometimes even months to get them up to a full dose where, therapeutic. And then there are sometimes even where I have to forego treatment altogether and just calm down the inflammation just enough to keep them from reacting so severely that they don't tolerate the regimen. And that's typically with, medications where I will definitely switch gears to herbal. I can control a drop at a time and not worry so much about, worrying about reaching that level of the medication where it's therapeutic, where herbals are a little more forgiving.
Yes.
So,
and you can put a drop in a glass of water and even thin
absolutely.
it out more, right? Yeah.
Exactly.
Okay. This is technical question. I have no idea what it means, but when it comes to ozone therapy, does it have to be 10 pass or what is the most effective method?
It doesn't have to be 10 pass. I find the most effective is MAH therapy, which is major autohemotherapy. It's the safest. So 10 pass is just running it back and forth multiple times. So in theory, you're kind of getting a higher dose, where MAH is using a larger volume. So it kind of, works out to be the same, I find, clinically. But I do find that it needs to be, that direct blood exchange to really, get the effect that you're looking for. There are other forms of ozone, and it's either ozonating water and drinking water. Some people will do, it kind of smells like swamp water. It's delightful. Minor, injections. You're taking sort of like a 5 cc syringe and injecting after you've mixed the ozone with your blood, and you're almost like you're auto-vaccinating. And then there are rectal ozones that you can do, which can actually cause a lot of inflammation with some people if you're not careful. So I do find that either 10 pass or MAH therapy, depending upon what you tolerate, seems to be the most effective.
Okay. And do you think that Lyme and co-infections will ever be given enough credibility that it becomes a checkbox on the diagnostic sheet so its insurance will cover more reliable tests?
Oh, I hope so. I can only hope. And I think that, as long as there are, the squeaky wheel, so to speak, like us out there, and, the more and more we recruit other people to advocate and the more data we put out there,
Yeah, and we just need a better test.
Like, we do need a better test.
I had a patient a while back. He was a very well-respected pediatric surgeon, orthopedic surgeon, and he took on the toughest cases in the country, right? And he had Lyme disease, right? So he set up a meeting with me and this other head of an orthopedic, and basically his message was, look, some of these, kind of non-specific orthopedic problems you see coming in could be Lyme disease. Are you willing, what can we do about this? So we had this long conversation in a restaurant, and basically at the end of it, the head of the orthopedic clinic said, okay, so we don't have a good test for this and we don't have a good treatment for this. And you want me to do what again? And this was somebody who was open-minded, right? And, it's just like, we just need a little bit, even though the IGeneX is a great test, but it's
still not foolproof.
It's not foolproof, and it takes a while, and it costs a bit of money right now.
Right.
There's that issue with it, even though some of it's, starting to be covered a little bit more regularly. But to do a whole tick-borne panel at this point,
it's expensive.
And to justify that, right? And it's different working in a clinic like you do, where the conversations with the patient is, can you afford this? But trying to justify that to an insurance company is a whole nother ball of wax. Because again, we're talking about the top-down expert saying, "What are you doing that for?"
Right. Exactly. Yeah. I always joke and say, sort of tongue in cheek, that it's going to take one of, either a really, really important person to contract the disease, sort of and God forbid anyone has, I wouldn't wish it on anyone, but it's going to take something like that big. And, or, some of those, heads of some of those big organizations, to
retire.
Yeah.
Let's just say to retire.
So whatever happens first. So I'm not advocating that anyone give someone
direct action. No, we're not. No.
Yeah. No. But it's got to be something that big, for that to happen. But we'll just keep plugging along and keep pushing. That's what we do. So.
Yes, and again, how long have you been with Dr. Bach again?
About 4 years.
For about 4 years. So you kind of came on as things were. You're one of the people who shifted this. You were on that wave where things really went from way out in the wilderness to now we're just kind of like an outpost town or something. Right. It's not you still have to look for a diagnosis. You still have to look for an LLMD, but it's not like you have to go looking under rocks. I mean, you guys were hiding before. You had to hide before, and it's not that bad anymore. It's not good by any stretch of the imagination, but it's not terrible. And it's still, there's a lot of work to be done. That's not what I'm saying, but it could be a lot worse. All right. Thank you so much. I'll let you get back to Noah, right?
Yes.
Yes.
One of them.
and the rest of your family. Thank you for giving up part of your evening. It's so important. And I want to leave you with the last word. Tell people how they can get in touch with you and Dr. Bach's clinic, your clinic, I should say, is part of that.
Mm-hmm. Right. Well, there you can follow us certainly at Facebook at Ken Bach. I also have a blog at DelSignore.com. And then we have an Instagram account that is NY Limes and PANS. So I'll have to send that to you. So we're online. It's exhausting, but we try to keep up with it. And certainly we're in Red Hook, New York. So a small area is very difficult to get lost there.
That's so true. Thank you so much. It's been a pleasure. And I have to come back and come down and visit you guys. Now that I know you, it's a definite excuse to do it once this whole thing is blown over and we're allowed to travel again. So
you got it. All right. Thank you so much for having me. Great to talk to you. All right. Take care. Bye-bye.
All right.
She is a wealth of information. That was absolutely incredible.
So much has changed. You remember some of our remember talking with Dr. Horowitz way back then? Remember that interview? And some things have changed so much in the past couple of years. So I know it doesn't make Lyme any easier to treat, but just the volume of information, the number of patients under treatment with credible people and people who understand the disease, understand physiology, who don't just have like one picture and are beginning to synthesize it. She talked about the silos to kind of break apart those silos.
Yeah. And they're willing to consider it even in even long-term treatments. It's really important.
All right. Thank you all for joining us. Thank you for being here. I appreciate it. And as you longtime Lyme ninjas know, this podcast would not be complete unless we left you with the Lyme Ninja fact of the day.
Did you know ninjas can make a stop sign say go?
Lyme Ninja Radio is a purely public broadcast and is not intended to be personalized medical advice for any individual's specific situation. Each individual's medical situation is unique, and Lyme Ninja Radio should not be relied upon and or considered as personalized medical advice. Lyme Ninja Radio is not licensed to render medical advice and should be considered simply the public opinion of Lyme Ninja Radio and its guests. Recommendations on specific treatment options are not intended to address any listener's particular medical situation. As always, contact your physician before considering any new treatment.